There is much concern also over various viral strains, particularly the UKB117 mutation, which so far does not confer added virulence necessarily, but seems to be substantially more communicable. This mutation has already been detected in multiple locations in Southern California, so you should simply assume that it's here. It does not appear to have an impact on whatever immunity is conferred by previous infection, nor on the present vaccine candidates. We are observing the other mutations, notably South African 501YV2, which has a similar mutation of spike protein. And I know we have a question about that, so I'll talk a little bit more about that later. Clinically, the infections appear to be the same, but they are a reminder that evolutionary pressure on the virus will select for these more infectious strains that will spread through the majority of the population that even with the current high positivity rates have yet to be exposed. That brings us to the vaccine side. The county has been allocated 158,850 doses by the state, and we've received 114,825 doses so far, with 33,405 doses administered to date, which does not count those county residents vaccinated in other jurisdictions by their employers. Now remember that those allocations include both first and second doses, so some are being held for that. And then most of the received doses have been allocated and shipped to hospitals and other registered providers, and those facilities are then expected to administer the vaccine to their employees and eligible populations. We do continue to ensure that vaccine is available as a priority to you, first-line providers and other healthcare workers who are likely to be exposed. And for this, I would especially like to thank the leadership of RCMA and Riverside Medical Clinic for the drive-through clinic, which is running this Saturday the 16th. Proof of employment in Riverside County and individual pre-registration is required, but the vaccination is free and RCMA is offering to host future clinics. I know we have a question about that and we'll talk more about it then. Meanwhile, the state and Governor Newsom in particular have made faster vaccination a cornerstone of the current rollout. And this week, the county will be moving into phase 1B, which opens up immunization for individuals 65 years of age and up, plus frontline essential workers in education, childcare, emergency services, food and agriculture, expanding soon to manufacturing, transportation, and facility services, as well as those general congregate settings apart from long-term care, which are of course already eligible. Right now, the county is running regular shot clinics at multiple county locations. Hours are typically 8:30 to 4:30. There is no cost to the patient or to you. And you can send your patients if they qualify and live in Riverside County, but a photo ID for age and or other proof of residency is required. And of course, they must have an appointment. That website is www.ruhealth.org/COVID-19-vaccine. And I'll read it again. Actually, I'll just throw it in the chat box. ruhealth.org/COVID-19-vaccine. Let me type that in here. And of course, if you yourself want to get vaccinated and have not yet, you can do the same. We will ask for an employee badge, pocket license, some sort of workplace letter, or something that would indicate that you are eligible if you are under 65. Your second dose is due 21 days after the first dose if you got Pfizer, 28 days after if you got Moderna. If your institution is not doing the second dose, you are of course welcome to present your immunization card at a county vaccination clinic. But again, as we ask, please have an appointment before you do so. With that, Dr. Holmblad, I'll hand it back over to you for the questions.
Okay, can you hear me here? Question number one, how are the 1 million doses of vaccine the governor mentioned going to be distributed by this weekend via the county or via selected organizations? When will the 1B Tier 1 going to be open, and how will Riverside County Public Health help to expedite the process in our county?
I think I got most of the second half of the question already, but as far as how the doses will be distributed, either via the county or selected organizations, the answer is essentially yes. The state has certain multi-county entities selected, such as Kaiser, Sutter Health, HCA, so on, that directly sends vaccine to, and then the county handles distribution for the rest. For these multi-county entities, the state regulates their inventory and rollout directly. As far as the remainder, we are working as quickly as we can to get vaccine out to those facilities that have registered. Of course, that has the expectation that those facilities in turn will act quickly to get them administered to eligible populations. As mentioned, we are now advancing into the points of dispensing phase. Where we are starting to service high risk members of the public directly. We intend to take the lessons that we learned from this to scale up to larger groups when we shift to phase 2.
Okay, thank you. Question number 2, we need to get moving on phase 1B. Is there a firm timeline for vaccine clinics and or for local pharmacies to start giving COVID-19 vaccine to group 1B?
Yep, the timeline's now. They may do so. Now, I will note for the record that the pharmacy rollouts and vaccination site contracts have largely occurred at the state and federal level. Some of these campaigns have interlocked better than others with locals, but we do still continue pharmacies to encourage pharmacies to register, and we have had some very productive local discussions with some of our local pharmacies, so more on that hopefully in the future. But as far as whether they can do that to that population, the answer right now is absolutely yes.
Okay. Question number 3, is there a plan to start an online vaccine pre-registration process for members of the public who are at high risk and would qualify for phase 1B priority? For example, seniors over age 70 with heart disease, diabetes, etc.
Yep, they can do that today, and we will accept appointments from members of the public. They just simply sign up on that same website. There are buttons there where they can select the clinic they want to sign up for.
All right. Question number 4, what is the false negative rate of curative testing? What percentage of the county testing is via this modality of testing? And finally, could a high number of false negative results may also be an added factor in the high volume of cases in Riverside County?
I suspect this question is referring to the FDA advisory issued on January 7th, which indicated a concern primarily with false negative results with the curative assay. This is a self-administered test. It is PCR based, but the sample collection is done actually by the patient. And this issue is probably amplified because of that self-administration bias, as well as the persistent questions which still exist for its performance on asymptomatic or pre-symptomatic individuals. The FDA notably did not indicate on the advisory what that sensitivity gap was, although the previous EUA suggests that the sensitivity rate for this particular assay ranges anywhere from 75% to 100%, depending on the extraction method and the amount of virus present in the sample. The other hidden question here is whether we should still be using curative self-tests, and the two biggest reasons why right now we still plan to is the fact that it facilitates large volume and convenience of administration. The state's testing incentives on case rate currently favor large testing numbers, and our surveys trying to get people in and tested have indicated people are increasingly unwilling to do nasal swabbing. And for those of you who've had it, and I've had a couple tests that way myself, it isn't a lot of fun. And I can certainly understand why, if we're trying to get good surveillance into our population, people would prefer this method. Currently, even considering that, curative testing is not the majority of county tests performed, but it is a significant proportion. Since symptoms can be minor or inapparent, we don't turn away anyone who is not obviously symptomatic. And we work with the individuals who are trained to staff these sites to ensure that we get as good compliance with the instructions as possible with the collection method that they're using. And also, just as a policy note, based on a lot of the misinformation which circulates about false positives, and I know we have a question about that later, so I'll go into it at that point. And because we also want to remind people that you can always test negative one day and positive the next, I'd really rather bias towards a lower but still acceptably sensitive test that has nevertheless high specificity, and being PCR it does, that people will have few grounds to question if it's positive and still continue to take appropriate precautions if it's negative. Naturally, of course, we will continue to monitor the FDA guidance on the test to see if a clear pattern results. And we're also talking to Curative to see if there are any technical changes to test administration to ensure that we are still getting the most accurate sensitivity we can out of the present assay.
Okay, thank you. Question number 5. Why is the monoclonal antibody EUA allocated only to hospitals? This treatment is for non-hospitalized patients who are mild to moderately ill. Hospitals are inundated with seriously ill patients and cannot spare the staff for this outpatient service. Can this be allocated to urgent care centers, FQHC clinics, or even infusion centers?
First off, let me say that I'm sympathetic to this view because we had a lot of questions when bamlanivimab and some of the other ones pop up. Is exactly how useful they would be given that they don't have an inpatient indication. So the answer to the question is yes, we absolutely can allocate this to those facilities which can facilitate it. We do need pharmacy information on where to deliver it to, and you should be prepared to receive entire cases rather than vials. Currently, it's 100 vials to the case. And the reason we ask for this is it's very difficult to ship small amounts, especially because we deal with the manufacturer directly for moving this around. That said, if you think that your facility can qualify, and we have had some inquire and we're working with them right now, you can either contact me directly or you can notify Dan Bates at EMD, who is actually the one doing the receipt, and he and I work together to make sure that this gets distributed out to the facilities that have requested it. In the meantime, we do try to get them out as quickly as possible to those facilities that do want it and are willing to receive it, because the hope is that it may stave off hospitalization in some of these cases. Again, the jury's still out. It is, after all, an EUA medication, and we're still trying to get more evidence on it. But I do agree that if it's going to have the biggest bang for the buck, it needs to be occurring in some others of these pre-hospitalized settings too.
Okay, thank you. Question number 6. How can my office participate in vaccinating our staff, our patients, and the community?
I'm going to interpret this question as very simply, how can I get vaccine? Because I think that that's obviously the first step to being able to service them. The old COVID Ready system some of you may have used is now transitioning to CalVax. That website, I'll go ahead and enter that in the chat box, also is calvax.cdph.ca.gov. That site is up today. I went ahead and checked it before I came on, and it answers. The site will step you through the registration process. If you have done this for other facilities, it is similar. Previously, I think it was our last discussion, I mentioned a minimum order for doing so, and there still is for direct shipping. Kaiser, which as you will recall requires ultra low temperature refrigeration, has a minimum order of 975. Moderna, which can simply be frozen, has a minimum order of 100. Now, through CalVax, you can order less than that, especially if you're only able to get Pfizer, you don't have ULT freezers, and you are not likely to use it within the 5 days required once it thaws. But if you do, please keep in mind this means the county ends up being the middleman, and we have to receive and parcel it out to you. Now, we're happy to do that, but do note it has an unavoidable delay because everybody wants to do that, and we may not be able to tell you exactly when it will arrive, and that may make it somewhat more difficult for you to plan. If your facility can take the minimum order size, you will be able to get what vaccine is available in stock that much sooner and more predictably. But either way, we do want to make sure that we're facilitating it for them because we just don't have enough clinic slots ourselves for all of our 65 plus, and we do want to make sure we're working with clinics to get it rolled out to those communities.
Okay, thank you. Question number 7. Are COVID-19 deaths increasing or just cases? Why does reporting on the subject focus on cases and not deaths?
Well, frankly, they're both increasing. Today, as I mentioned, we had 92 deaths reported as mentioned in the monologue. Now, note that this does include deaths outside of that 24-hour window between yesterday and today that have only now just been confirmed by the medical examiner, but that's pretty much true on every day that we report those deaths. Recall that on average, deaths lag by approximately 4 to 5 weeks based on current medical care standards. On the whole, about 12% of individuals who come up positive will require hospitalization. About 20% of those will wind up in the ICU. That's why we do tend to focus on cases, because it's an excellent predictor, unfortunately, of how further impacts to our healthcare system are likely to be felt. The current surge in cases started in early mid-November, give or take. If you look at our case curves, you'll notice that there was an analogous rise in deaths somewhere around early mid-December. And even when we do peak in cases, and hopefully that won't be in too long, unfortunately, deaths are likely to continue at elevated rates afterwards for at least a couple weeks, just as before. The medical examiner's office does send me regular reports on individual autopsies that they conduct, and we are seeing more deaths that are also occurring outside of hospitals with people who tried to write it out at home. Unfortunately, these people are in the 45 to 64-year-old demographic, and quite a few have no known medical comorbidities. Even though we continue to focus on the death situation within the hospitals, I think it's also to point out how many deaths are actually occurring outside of the hospital setting, which we are trying to account for in our daily numbers as well.
Oh, I agree. Question number 8, are level one paper masks sufficient within office setting, cloth masks within the office setting, or is an N95 necessary?
For the purposes of office setting, I will assume that this question meant a medical office. And frankly, I would strongly advise the use of medical grade surgical masks as a baseline where patient care or contact occurs. My rule of thumb when I see patients is that if they have respiratory symptoms, I will use an N95, and for the others, I will use a surgical mask. I must be doing something right. I'm still testing negative, but that's generally the rule of thumb that I use. But I would say you should not go below a medical grade surgical mask in a medical office setting. I recognize that fabric masks may be more convenient, but I think that the best evidence to the extent that it exists in some of these circumstances is provided by the medical grade PPE.
Okay, thank you. Question number 9, does the vaccine protect against the new, more virulent strain of COVID-19?
Pfizer has indicated that their vaccine continues to be protective against mutations with what they're calling N501Y. This is a single protein change of the single amino acid change in the spike protein. And this mutation happens to be present in both the UK B117 and South African 501YV2 mutations. This single amino acid residue change appears to be what's responsible for their increased communicability. It appears to make the spike protein bind more avidly to the cellular receptors. But Pfizer also tested against this and 15 other mutations previously and has so far stated that they appear to be inconsequential to their vaccine effectiveness. Moderna and AstraZeneca are doing similar testing but have not yet reported the results, though there is anecdotal evidence to suggest they are also expected to show continued efficacy.
Okay, well, that's good news. Question number 10. Do people that have been vaccinated for influenza and COVID-19 need to continue to wear masks?
Frankly, yes. Until we have a clear idea on how much the vaccine reduces transmissibility in vaccinated individuals, and also keep in mind, too, that these new mutations do increase the R0 of the virus and therefore the necessary threshold for herd immunity. Previously, the bar was somewhere between 60 and 75% of the population. But with the early estimates of the new R0, especially if these mutations start taking over with the current strain that's in circulation, it may need to exceed 80% or more. I do note one promising sign, though. Israel, which is the country presently vaccinating at the fastest rate, they're using Pfizer's vaccine candidate, and they have preliminary data from several of their cohorts suggesting a reduction in transmission anywhere from 33 to 60% 14 days after the first dose. That's quite substantial, but that is not 100%. Even in the best case, that still indicates that transmission can still occur at about 40% of its previous levels. That means that is not an argument necessarily to dump masks after getting both doses, but it may be an argument, and I know that I've heard some discussion about this at both the federal and state level, that we should simply say, damn the torpedoes and get everyone a first dose as soon as possible to try and cut down on transmission. Until we get firmer information on that, I would say watch this space. But even if that turns out to be true, the fact that some transmission is still possible suggests that we should still continue to be using masks and following all of the other precautions, at least in the short term, until we achieve something meaningfully close to herd immunity.
Okay, thank you. Question number 11. In addition to encouraging, should we make it mandatory to require our employees to get an FDA-approved COVID vaccine? All of my employees have at-will contracts. They can be terminated for any reason. Office staff is small and we cannot have remote employment. I am concerned if an employee contacts COVID and passes it on to a patient who later sues my practice for allowing an employee to work without a vaccine.
I am not an attorney, and you should talk to an attorney about this if you think that you may have legal exposure, but I'll say this for what it's worth. Last month, the Federal Equal Employment Opportunity Commission indicated that employers can require workers to get a COVID-19 vaccine and bar them from the workplace if they refuse. This is important given that the Americans with Disabilities Act of 1990 limits employers' ability to require medical examinations as a condition of employment. And the commission has essentially ruled by making this finding that the administration of a COVID-19 vaccine to a worker does not count as a medical examination, which would be regulated by that act. However, you are still obligated to ensure that any pre-screening questions you ask about vaccination are job-related and this, I'm quoting directly from the statute, consistent with business necessity. Again, this would be a good question to run by an employment attorney to ensure you are within the statute if you are concerned this is going to be a major problem for your practice.
Okay. Question number 12. If we are exposed to someone that tested positive to COVID, how does having received a vaccine change what you have to do in terms of having a quarantine? And then as a follow-up, how about if you received only one dose? Or is it only after you receive the second dose that it will really alter your need to quarantine?
Unfortunately, the forward answer to that entire question is we don't know yet. The CDC has not said definitively, and until we have a better idea over how communicable an immunized individual can still be, right now the recommendations for quarantine are unchanged regardless of the number of doses you may have received. And this, the vaccines seem to have extremely good track record as far as preventing serious illness. But again, part of the reason with quarantine is also to break that cycle of transmission, which we're unable to currently rule out right now. In fact, some countries like Australia have indicated that they intend to continue a full 14-day quarantine even for vaccinated individuals until there is better data. And it should be noted, of course, that none of the vaccine candidates, even the Moderna one, which is 95% plus, is fully effective. And unfortunately, right now, we are nowhere near herd immunity, naturally or otherwise. For the time being, regardless of your vaccination status, if you have an exposure, you should still be quarantined for the standard period until at least we get some better clarity on this at the federal level.
Okay, thank you. Question number 13. In addition to available hospital beds, does the county track numbers of available nurses and other staff? How do things look and what happens if there's a shortage of nurses?
Since healthcare facilities and staff are regulated at the state level, there is no stipulation that requires this information be reported to or monitored by us at the local jurisdiction. But we do have a good working relationship with our local CDPH licensing and certification branch, and they work with us on staffing problems they have identified, as well as with OSHPD, the Office of Statewide Healthcare Planning and Development, which is also at the state level. Facilities with impacts can always self-report to the EMD MOAC program, and we help connect those facilities to assistance, including any local resources we can deploy. This not only includes acute care facilities, which we have assisted recently, but also long-term care facilities and SNFs. You can do this as you would do any other MOAC resource request, or if you just have some general questions about the process, you can notify me and I can help you with it.
Okay, well, thank you very much. Question number 14, what is the probability of a false positive PCR nasal swab test? And as a follow-up, the same patient got an antibody test 10 days later, which was reported as negative. Should he have another antibody test? 4 household contacts had negative PCR tests 7 days later.
This is the other side of that question we asked earlier, so I'll just sort of pick up where I left off. As a whole, PCR testing generally has a bigger problem with false negative results than false positive results. In general, the test is highly tailored to those specific genetic sequences, which are very unlikely to react with other infectious agents or even other coronaviruses. So the false positive rate which exists, and there is a small one, is almost entirely a factor of mishandling or issues with the reagents themselves. The test also cuts off at a certain number of cycles. Usually the cycle time is 35, above which the test is considered negative, or 35 to 40 on some assays is considered indeterminate and they need a retest. The current overall rate of false positive PCR tests in vivo, unfortunately, is not precisely known because it varies on the test. This is easiest to ascertain in those countries where a single or small number of commercial diagnostic test vendors happen to dominate. In the UK, the Lancet had a recent study which estimated it at somewhere between 0.8 to 4.0%, which would equate to a specificity range between 96 and 99.2%. The Canadian province of Ontario estimated theirs at less than 0.01%, which would be greater than 99.99%. A better question, I think, in this case might be to consider the positive predictive value of a positive PCR test, how likely a positive test is actually to translate into a finding of disease. Obviously, if you think back to your biostats, that number is increased by prevalence, and we got a whole lot of prevalence around at the moment. In such a situation, then you might well ask about the sensitivity of the antibody test, which they use, which varies quite widely. I noticed that this specific question talked about doing the antibody test at 10 days. For some of the antibody assays, their sensitivity at that range may be as low as 70%. Some of them do not become sufficiently sensitive until about 14 days after the onset of disease. And of course, that's assuming we know that the 10 days is accurate. That would be 10 days past exposure, but the incubation period could be anywhere between 2 and 14. That said, I would have expected at least somebody in their house to have tested positive, and certainly at the 7-day mark. But it's also possible they had an infection within the last 2 to 3 months, which was never tested for before, keeping in mind that people shed virus for sometimes afterwards. And if that were the case, and there's presently no way to know, I wouldn't consider that to be a false positive test because it is legitimately positive, but it's no longer clinically relevant. These kinds of questions are why I have tended to bias for slightly less sensitive testing so that people don't start questioning a positive result they get more than they already are, which I think is a greater evil with the amount of virus that we have presently circulating.
Okay. Question number 15. Do you need facilities and or staff to provide COVID vaccines to the public? We can potentially use one of our Sandals Church campuses with our own medical volunteers if needed. We would all be licensed healthcare workers, including physicians, NPs, PAs, and RNs.
Well, I'm certainly not going to say no. We do need to ensure that we have sufficient capacity and good, well-distributed locations, especially as we start looking forward to phase 2 and phase 3. If you do have such a facility in mind, though, I would, however, ask that the facility itself contact us rather than having us be the intermediary, just to make sure that we're working with them directly. Obviously, we have to make sure that we have any necessary memorandums of understanding or other agreements in place. We don't want any liability to be assigned to that facility either. You can just notify me directly if you like regarding this facility. But again, please, since you've mentioned a specific institution here, if you could have them reach out as part of that, that way I'll know that they're fully on board and we can get that to the right people to talk about it. We may not be using these facilities a great deal right now, but I can guarantee you that we'll probably be reaching out to a lot more as we start getting bigger. We already did this in some small numbers for our testing. We work with a number of churches and other religious institutions to try and get in their members of their community, and we'd certainly be delighted to work with them.
Okay. So far, RMC is being permitted to host a vaccination event. What about other groups or consortiums?
Well, this one I'm going to give to Dolores.
Okay.
Hey, well, thank you. And I'm Dolores Green. I'm executive director with the Medical Association. If you haven't, if you don't know me. So RCMA has been asked by RUHS to help do vaccine clinics for the healthcare providers. So for physicians, practicing physicians, and their medical office staff, since it's important that we get you all vaccinated as soon as possible. So we reached out to RMC at Riverside Medical Clinic, and they agreed to partner with us in hosting a drive-through clinic for, again, practicing physicians and their medical office staff. And that is scheduled for this Saturday. And Richard just posted in the chat line the registration information. You have to register and you can't just show up. So please go online if you haven't already registered and you and or your office staff needs vaccination. We are looking to host other sites around the county, but at this point, this is the one we have, and I highly encourage you to come in and, again, register first. You can't just show up, but we're going to be giving 1,500 shots on Saturday.
Wow.
And we have, I think, about 800 so far signed up. So we will close down the registrations by about 1 o'clock or 2 o'clock tomorrow afternoon, so we can get everything processed, enter it into the Epic system, and be ready to go on Saturday morning. So there is the link in the chat box to the registration form. And I encourage you all, if you haven't gotten your shots, or your staff, to please do so.
Okay. All right. Do we have, I don't have availability to get to the chat box. Are there any questions in the chat box? Dr. Kaiser, do you still have time?
Yeah.
I can't see the chat box.
I'm flipping through a few of them. I think that most of them were mostly comments.
Oh, okay.
One person commented on the clinics on the website listed all say full. I'm assuming that means the county ones. Assuming that that does, we are opening up additional clinics coming up. It just, these are the ones we have coming up immediately. So just stay tuned. We're trying to do that as much as possible. But again, if your facility would like to participate, by all means, please register. If you can take large volumes, that would be even better, because we can get that rolled out to you more quickly. There's also a question from Aileen Fredlin, who asked, for healthcare workers, primary care settings, some employees were refused since they were asked if they have direct contact with patients. They had appointments and have been working since the pandemic started, but were refused since they do not directly interact with patients, but they come to work every day. I would like to point out for the record that wherever possible, please use telework for your employees, especially those who may not need to be in the office. I'm going to assume that these workers have to be in the office for one reason or the other, but do not actually have a patient care role. The state has not been exactly clear on what to do with this particular population. However, since we've moved into phase 1B, I will say that there is some discussion that healthcare workers who do not have routine patient contact may fall into this group. What I would recommend that you do, if you happen to have a population you believe that may be at risk for your office, or you're in an office where you believe the risk setting to be there, we would ask that your employees go to these clinics with a letter explaining the situation and why they qualify. I think that that would be the simplest way of doing so, to let them know. But I would make sure that you have on whatever documentation you send along with them, and notice that they are an employee of a healthcare facility and that they are required to be present on the grounds where patients may be. And I think that will be the easiest way to get them in there. Because obviously during the vaccine shortage, which we presently have, we would like to optimize that for those people who are likely to be exposed. And the way that you've described it, I sort of see your point, but we also need to make sure that it's very clear to the people who are trying to winnow this out at the front lines exactly why your workplace may need this particular additional protection. Also, there was a question, not sure how this one is to be read. For those who have had COVID-19, how long should they wait until they get the COVID vaccine? Fauci recommended 90 days. I haven't heard that there's really any lag time between when let's say that you've had COVID-19 and you've recovered. Obviously, you should wait until you're better, but that would be generally the case for most vaccines. After that, I have not seen anything that suggests that you should not just go ahead and get it. As it stands right now, we really don't know how robust or long-lasting that particular immunity happens to be. And frankly, if it were me, I'd really rather make sure that I have some more predictable immunity of the vaccine than having to rely on whatever natural immunity may have resulted from the infection. So I am not aware that there is any clinical recommendation that there should be a timeout period, assuming, of course, that you have fully recovered. You can do this by the 10-day, 24-hour rule, assuming that you no longer have symptoms. There's another question from Dr. Gowda asking, side effects from vaccines, how many days are they lasting? The vaccine side effects seem to be similar in scope and severity to those that you would expect from the flu shot, maybe a little bit more severe. We've seen them a little bit more with the Moderna candidate because the dose is higher. Nevertheless, I would still consider the side effects to be relatively modest. The longest that we have heard locally of somebody having side effects ranges on a couple of days, which would be about what you expect from that subpopulation, which says the flu shot always makes them sick every year too. We have not had any serious anaphylactic responses to that reaction in Riverside County, although that of course has been reported. And in your facility, should you administer these vaccines, you may wish to observe them for a brief period, which would just be good practice anyway. Where can a 16-year-old get Pfizer vaccinations? Right now, nowhere. unless they happen to fall under the healthcare worker certification, which I kind of doubt. Right now, they would be at a lower tier up in the future. I realize that it's certainly important to get our young people immunized as quickly as possible, but with the limited vaccine we have, we're going to be prioritizing those who are at the highest risk of serious medical complication. And I think the data that we have to this point shows that the older you get, the worse off you are. Whereas individuals under 18, the risk to them is quite small. We would like this population to be immunized because of the rare risk of serious disease that they have, but more importantly, to prevent further transmission. That's just going to be a factor of what vaccines we happen to have. Also, another question, is this Saturday open for medical residents and students who rotate in the clinics? The answer is yes. Please bring your ID. Best, if you're able to furnish some sort of letter from your sponsoring institution, that would be great too. But as long as you have some sort of ID that clearly identifies you as a medical student or medical resident, you are welcome at these clinics. Again, however, you must have an appointment.
And Dr. Kaiser, I will jump in too that those medical residents and students are also welcome at the RCMA's vaccine clinic at RMC on Saturday also. But again, they must register.
Absolutely.
Okay.
And that's all that I see, Dr. Holmblad.
Well, Dr. Kaiser, thank you very much. Once again, it's been my distinct pleasure, helping co-host this with you over these past 9 months. And hopefully we don't have to have too many more of these monthly meetings, that this will be a thing of the past. But once again, thank you very much. And I want to thank all our attendees tonight here. It's been my pleasure. And so we're signing off. Thank you again, Dr. Kaiser.